Hello from New York once again.
Dr. Dangus, Dr. Kinney, and I see.
Yes, the fellows.
Yes, can you guys hear us?
Yes.
Go ahead, Dr. Kinney.
Yeah, Roxana and Ajay and the entire panel. Thank you for inviting us for this excellent session. We've been watching it ever since it started. Myself, Dr. Kinney, and I have Professor George Dangus, who's going to be helping me with this live case. We have Denizan and Pierre as our fellow, and the rest of the team. Actually, Kiski will be the one who is our faculty for the imaging. So I'm going to show you the slides, if you can start seeing the slides. So actually, I put it as case 2 because we did our first case last year for TIO. So this is the second case we are doing this. First case, for this session from us, which is a 92-year-old male. Though he's 92, very active, he's an accountant and he still works. Presented yesterday with unstable angina, troponin was still negative. He had risk factors for coronary artery disease and prior PCIs like you see here that have been done in the past. So angiogram done yesterday did show that he had 3 vessel disease. Culprit was the distal RCA and he had significant left main as well as the LED disease. I'll show the angiogram. So this is the right coronary artery PCI that was done yesterday.
Very calcific as well, as you see.
Yes. So today the plan would be to do a high-risk left main PCI of a calcific lesion, and we always see what is the predicting patient risk factors. Like we know, we do use STS as well as the syntax. STS was about 31, syntax 2.2, despite him being a 90-year-old. And we always use appropriateness criteria. With left main, always is a surgery is the most appropriate, but with this age, I think it becomes M. So if you can go to the angiogram right now. Right coronary artery today looks beautiful. And here we are with the left. So significant distal left main, and what you see there is aneurysmal look, both of origin of the LAD as well as circumflex. I just doing this, poor man's view of understanding calcium, tram track calcium, even before we inject any dye. And this is the cranial picture.
So you guys wanted a complex case that includes calcium and bifurcation. So we thought we'd give you 2 bifurcations in one case, left main and LAD diagonal in combination with aneurysmal disease of the side branches. We can undertake some discussion. Meanwhile, I can tell you that we try to do some imaging. The catheter wouldn't advance. So we prepare right away to perform the rotablator 1.5 burr because nothing would advance through that. So with this knowledge, go ahead with the discussion.
Yeah, so let's go to the panel. Ajay, looks like you want to say something. Some will say, well, you couldn't pass the imaging. Maybe you use a very small balloon and still come forward to use the best possible technique for your ablation, but let's hear from you, Ajay. Any comments?
Simple, basic things that we don't talk about enough. You can't hear me? Can you hear me now?
Now I can hear you. Now we hear you. Go ahead.
Just some simple, basic things that we don't talk about enough that shows, the experience of not only Dr. Kinney, but the whole Sinai team. First, they took the picture of the right coronary artery before starting on the left, even though they fixed it yesterday or the day before. Because if something had happened there and you didn't know about it, and you embarked in this 92-year-old on treating an unprotected left main, you wouldn't know. So things like this, very basic steps are really important in the case. Similarly, you can be very dogmatic about imaging, but if the imaging catheter doesn't advance, you don't want to shove it through and make him very ischemic. So you immediately make the decision for rotablator. You do it quickly, efficiently. Again, I think because of the experience of the team, they don't need to use hemodynamic support. They do this in a very straightforward fashion. But these little steps are really important for these sick patients.
Absolutely.
Let Neo, please.
Any comments, Natalia?
It's not making a turn. I don't want to do it.
I was just thinking myself when I do these cases, if you use a balloon to get your catheter in, you will have like the broader ablation regret. So I think this modern belief that if the imaging catheter doesn't go, then you're likely going to need rod ablation or CSI or orbital.
Give me a run through wire.
I think
Okay,
it's
ready.
a great approach because this case has not only severe calcium but very extensive. So you don't want to be here. You won't do one inflation. You will do several inflations in the left main and LAD, risking the flow. So I love this approach. If the imaging catheter didn't go, then you go to rod ablation.
So Dr. Kinney, tell us, what did that feel like? It felt like you
it was well, the 1.5 burr. Yeah, we selected the 1.5 burr because it was clearly small on the left main part, but it was very adequate in the LAD diagonal part, and you saw very clearly. Keep it straight. Keep it straight. You saw very clearly that it struggled a little bit in the second lesion. Why again? Because it's really appropriately sized more for that lesion. If it was solely a left main, 1.75 burr might have been undertaken, but clearly we try to do the very stepwise. As you can see, put the burr up. We use Dyna to actually put it a little bit in the left main, just a little bit align it out of the guide, and then it was a very slow movement, stopping every 10 seconds in order for the vessel to breathe. There was no hypotension. The patient went blood pressure at systolic about 100. We supported it with a little bit of neo, just preemptively, one can say. There was no bradycardia. Heart rate remained at about 50, as it is right now also. So no major event hemodynamically. And what about the wire side by side with a run through now, and following that we're going to give you an OCT imaging of this situation.
So I think like George mentioned, as I was at the second lesion, you see that just at the level of the diag, I was having some issue in advancing, so we had to do 3 runs, but it's aneurysmal, so you got to be a little cautious. If it had not gone with the third pass, I would have just come out. There's a risk of perforation when you are at this level of vessel.
Well, that's an interesting point.
If you really need something, you may have to downsize the burr, because we were at 1.5. And like you mentioned, you needed 1.5 for the left main. Probably it's a little small size for the left main. And let us see if we can do imaging now to understand what the rotational atherectomy has done. I just want to show another point for any fellows that are watching, that if you see here, so I didn't want to do multiple views, so thought let's wire in this view. Now, in the cranial view, I kept getting into the circ because the way the aneurysm is probably facing. So you try a little bit. If it does not, immediately change the view. So in the caudal view, you see that my wire was just kept getting into the circ. So you then change your wire movements. You see that, your finger movements, so that it is facing up into the LAD, and then we are able to get into the LAD.
OCT.
Yes. Now we will see if the OCT catheter will advance at this time. Yes.
Yeah. Well, I want to say, just theoretically speaking.
Rota wire that you.
No, filter first. Filter first.
Microcatheter.
Filter first with a turnpike and change for the rota floppy wire. And just to complete the aspect that very eloquently Dr. Kiri brought up, if the 1.5 burr wasn't advancing and we wanted to do something better, the 3 options. One is you increase the burr rate, RPM. The second one, which of course is in this case could be risky. The second one is you downsize the burr to 1.25 in this case. And the third one would be to change the wire into the rota extra support around the rota floppy. So I think that's very teaching point. These are the 3 things that can be done.
Give me a bigger syringe.
In general. So right now we're getting to ready to continue from here.
Okay.
We're ready to continue and inject for the. Don't worry about this one. I'm gonna inject from right here. It's fine, no problem. We'll inject here. We're gonna do the. Go forward this way. We're gonna do the OCT right now and doing the setup to inject the very large volume that needs to be injected in order to create the column of contrast that's needed.
Okay, so
let's do a little test to see where we are. And again, you got to pull the guide a little bit. I don't know, but
some dye. Yeah.
No, it's
See,
not.
then it's
not going to be.
It's a little dangerous, tricky situation here.
All right.
Nice
let's see. We need a 14.
1 second. Enabling 1 second.
Let me know. So I have to do a synchronized injection here.
Yeah, please, Cine, inject.
Cine. And I'm injecting now, and the whole thing goes back very nicely, actually. But the guide popped out just a little bit in the end, and I think we're going to have the whole vessel. It's very important, this imaging, because with a new system of the OCT, we can do many more sophisticated analysis very easily, and we're going to see it very soon. We can not only see the side branches very clearly in their location, we can work in the longitudinal view, and we can see, we are pre-marked to see only the arcocalcium over 180 automatically. We can do measurement of lengths, very important in this particular case, but also have automated measurements of not only the lumen, but also of the vessel, EEM, in different cross sections. And we can see all those things laid out in the longitudinal view that Keisuke is ready to summarize for us.
Sure. So I'll start from this is the after the D1.
Show Keisuke?
Yep.
No, I'm saying them. On
this
the
is after the D1, kind of aneurysmic part. So now come to the level of the D1.
Tell them in the longitudinal view where is the left main and where is so they orient themselves down there, and then show them the cross section.
Sure. Now the new software shows the left side is the proximal, the right side is the distal. So I will start pull back from the distal. Now it's a level of the D1. And I now come a little bit proximally. So you see that already we did at 1.5 bar. The surface of the calcium is shaped a little bit. But now come to more proximally, like through the vessel, a lot of calcium, like this is all calcium, like a 270 calcium. And now come to the proximal LAD, this is a proximal LAD aneurysmic part. So now come to the distal left main. It's definitely tight, like a 2.4 area. And even the proximal LAD left main has a 360, very thick calcium. Like all the way proximal left main has a all diffuse, and osteo left main has a calcified nodule also. Total length is 36. Left main size is like 4 low, but LAD size is like a kind of a 3 or something like here. But start of the program.
Okay, distal left main. Tell us, you think rotational atherectomy has done enough? Do we need extra?
We need a little IVL in the left main.
Yeah, still like a 270 thick calcium. I
think a cutting balloon.
Yeah, maybe that's the discussion point. I think.
Or a shock.
Or a high pressure balloon, which we're going to try right now. We're going to try right now a high pressure balloon in the left main.
A short area of super thick calcium.
Yep.
Oh no! Let me get
Distally though, I saw a lot of still lots of calcium.
True.
What did you guys think? I mean, I probably would opt for a shock wave here or a cutting balloon or something.
Okay, go.
We're going to do a high pressure balloon right now. We're doing a high pressure balloon right now.
I think, Roxana, the anatomy of the calcium in the 3 orange segments detected by Ultron had almost the criteria for an IVL. It's like superficial, very thick calcium that is like circumferential. So problem with the IVL now, we have the 120 pulses, but it's hard when you have multiple segments with this calcification. But at least the distal left main is very thick calcium with a good lumen. So I suspect rod ablation is not going to do much modification at this point.
Okay, good.
And this seems to be expanding pretty well. I think the problem is that so that we think this is best with IVL has not been tested
in a cutting balloon
way against balloons, and balloons often will
either IVL or nothing.
Let's see what happens with the repeat imaging. One thing I would also say about this
OCT
again?
Go up again.
We're used to interventional meetings where people always show the new, latest, and greatest thing.
Bang, bang.
And you remember your iPhone; it gets updated every year. This update with Ultron is not like your every year iPhone update. This is legitimately, and I don't say these things very lightly, but it's legitimately a really, really
nice.
Big
Take a picture
with the system compared to how it was before.
Yeah.
And so I think that folks that haven't seen it yet will really actually enjoy using it.
I think we need, I would do
No,
IVL
And
up
one
there.
question:
If you want me.
are they
Very, very
using the
Let's do
are
IVL.
they using NC
Not ready?
or
Not set
OCM
up?
balloon there?
This is the NC balloon,
I think it's an NC
high
balloon.
pressure. Yeah.
Was NC 3O balloon at 22 atmospheres proximally and at 16 atmospheres distally. I think in the distal part we did a good result. And by the way, you can watch now in the OCT map that we have at the bottom left. You see the orange zones are exactly where the calcium is over 180. That's pre-marked. And you can see the round dots are where the side branches are. So, and the total length is 38 from ostium.
36.
36, and we have marked where the 38 stent can go to cover a 36 millimeter lesion from exactly where we started imaging, which actually kind of generous because there is an area of a good landing zone after the second diagonal. So we plan to go with a 38 long stent. The question is how everybody feels and
About
how
the
Dr.
distal
Kiri
left,
thinks
yeah,
about the
distal
distal
left
left main. And
Go back to the distal left main.
should we do
OCT?
a 3.5 cutting balloon there?
Yeah, so this
Let me ask Ajay, why did you say go with the cutting balloon and not IVL? Go back to the, yeah.
So this is a distal left main.
Well, I mean, we're doing a trial to look, but one of them is about $4,500 cheaper than the other. So I figured maybe we would try that. Also, the length was not that long, and so my feeling was that if you could affect the fracture with the cutting balloon, then that would work. I do think you have to go up again though, because I don't see a big fracture in this
Still
proximal
thick
area.
calcium,
I
276.
feel
IVL?
like the left main is
Something
not
needs to-
adequately
Well, you didn't
done
prepare the
unless you
yeah.
re-image.
3.5, right?
I can hear
Yeah,
from Just and
3.5.
David. Just, what would you do next?
You want to do another OCT? No, 92.
No, we go here.
Volume in the left main.
Why is the
I
left
don't
main?
think
Why is the
they're
pressure so
bleeding a
big?
lot, but I think the only way to know
You're
is
giving,
to repeat the imaging and see how this lumen area of 3.0 in the left main increased. And if that now increased to 6.0, I think you did the job.
So following your discussion, we're proceeding with a 3.5 IVL.
You need to test and re-image.
We need to test it. Let's, and David, you agree with
Loaded.
that? I think I like
No, I
to
think
see an imaging. I'd like to see the image for the left main.
Yes, I'd also happy to use the cutting balloon here first. I mean, I think it's extremely likely that you're going to need to do a bit more than you've already done. The cutting.
You want imaging again? No, you tell them.
No, we cannot do imaging. Too much dye.
I think, I mean, I use
No, you're doing the dilate again, yeah?
almost uniformly. It's a partly a cost thing, but it's extremely effective. So I would do that first myself, and then see what we've got with the imaging.
Yeah.
Dr. Kinney, what are you doing next?
So we decided to go with a 3.5 IVL. We're going to spare further imaging in order to save dye in this very old person with 2 procedures within 2 days. So the criticism is well taken, and we're going to do several inflations with this IVL 3.5 in the left main area. We feel we have a very adequate advancement in the. Pardon.
Good, enough. This is a 3.5.
Okay, bang. IVL, deliver. We need to go a little bit in.
You want to? No.
Yeah, we don't cover the. Oh, yeah,
LED?
maybe we're okay.
Yeah,
Okay,
we're
then.
good.
All right. Where
Like
are
they
we?
said, it's 120.
Well, what is the team-
Impulse.
what is I think the panelists are understanding why you're doing this. So that,
Yeah, no, this is very
obviously
reasonable.
it'd be
Nobody's.
great to- yeah.
Our understanding is very clear because in our
Morning
previous
discussion was exactly, we don't really know, and so
in-
this is
in-
a very good strategy.
in our last angio, the LAD was bigger than the left main at this point. So we want to get a better expansion of fentanyl.
No, I will. Now
Yeah.
get into the ostium. Yeah, because we have to come up to the ostium.
Yes.
Yes. A lot of dampening. Okay, go.
I hope it
This is
will
3, even
advance.
3.5 looks small. So you said left main was 4.5?
4. Yeah, this EER is 4.5.
Yeah, that we are
But
not doing.
I
Okay,
think
down.
4 is a good one, safe one.
We'll stay back in
Let's see
the.
if it goes though.
We'll do OCT now.
Wanna
Get
use,
OCT. Go.
One
protection,
second.
Here, this is a
advance.
very high risk
Okay.
intervention in a 92-year-old.
Let's put it a little bit more into the bang. Oh,
Go.
very good.
Anybody on this panel
Yeah.
would want to have Impella? These guys are doing just fine without Impella. David?
Yeah, no, we wouldn't use Impella. I mean, we would in the trial. We were in the trial with it, but otherwise, we don't.
It opened up.
I think as long as you've got
down.
wires down the muscles and you don't.
Okay, get OCT ready.
One more.
Okay,
Give a little bit more. Give a little bit more. Right here.
Go.
Right here. Oh, spend the money. Give a little bit more.
OCT ready.
Bang.
We deal with high-risk cases all the time, and I think Impella sometimes gives people
two more we need to do at least. You all of them exhaust.
Because of course,
no, remember time. We don't have
much okay. We'll do fine.
A certain amount of risk to the patient in implanting the system. So
advance it a little bit more.
Advance
it. Get good.
Assist.
Dr.
So 3 fights, 3 5.
Why did you choose against Impella here?
Against Impella, access was borderline.
Access,
what do you think?
Borderline access in an elderly patient with EF of 54. It's like not a true indication, though it's a complex PCI.
Yeah,
yes,
definitely a complex PCI, but let's do one more.
The biggest challenge.
A little bit back.
Biggest challenge with all the MCS is access. Yeah.
Yeah, and also I want to let everybody know this case is very complex. We have a PRU level of 140 on clavics to respond to the patient. A little bit back. Okay, let's do one more here.
That's great, George. But I would also say that, in Excel, that MCS was used in a very small fraction of the cases, less than 5%. And for a normal EF, you fix the right. I don't think you need it.
Well, I mean, in all honesty, we are inflating in the left main.
Ruptured.
We have in the left main. We have in the left main quite a bit of time, so Impella might have been well taken. Let's see where we are now. We're removing the balloon.
Did you guys see that there was a rupture of the IVL?
Yeah.
Have you had that experience? We have had this experience now.
Yeah. So the pressure remains 140/80, so that we know. We'll take a little picture.
Okay, let's take a quick picture.
Take a quick picture.
Yeah, no,
okay, ready?
Okay, let's take it now. Prepare the OCT, please.
Yeah.
Good. Oh, very good expansion. Very good expansion. Want to do OCT or just put a stent?
Now, ideally, we have to do an OCT to understand. I think I'm just going to look at the left main. We already have dissection. I'm just going to stent it. Yes.
I'm telling you.
OCT?
No.
No. Stent.
Yes.
3-0. 3-0-38. What is it?
So what we'll do is we'll take a 3-0-38. We start from the diag level, come all the way to the left main. If we may need another short one in the left main. I think we'll cover it. Yeah. Now D2 had a lesion before we started, and we knew we are not going to touch that. Yeah.
Yeah, there is an intermediate lesion, 60 to 70% in the second diagonal.
Yeah,
and we're gonna leave this alone.
3-0 may, depending on the stent type, may not go up big enough in the left main. Is the only thing. So
that's
better off.
Left main is a 4-0 to 4-5. But
we're definitely planning to post dilate the left main.
No, they're saying they go 3-5.
Too big. No, it's fine. No, the 3-5 is too big for the distal. We're gonna get a dissection.
True.
Undersized, deploy at 10, and then we posted a left main.
No, it's just fine.
Okay.
No, it's very risky.
Professor Dangus
It's very risky for 3-5 in the middle AD, and I'm nixing that.
We have to listen to Professor. Come.
Which stent are you using? Because it actually depends.
Zions.
Which stent is it?
We're using Zions.
Yeah, Zions was used yesterday. That's one thing we follow. That was used in the RCA. I know it's only one day,
let me take
but no, let me put the stent.
It's not going to get to 4-5, I don't think.
Very good. Okay, let me take out.
It'll get up to 3-7-5. That's the only challenge.
I have a feeling you're going to need another stent anyway in that proximal area.
Okay, let's see about that.
Okay, now some dye.
Okay, come a little back, please. Way too much.
Yes. Okay.
Yeah, it's good.
Come a little bit back. And a little bit back.
You want more back? No.
Yeah. A little bit back.
I think we put another short stent in the left.
A little bit back?
Yeah.
No, just avoid it. Cine. Let's cine this.
Go for the second
Good
stent
injection.
in that left main.
We're perfectly fine. Let's take it up here.
Yeah, it's exactly OCT shows.
You're very good.
Distally. Okay.
We're on the fat part.
Okay.
Good?
Go up.
I think you're.
We may need a short 8 in the left main. That's okay.
All right, let's see about that.
Now after this we can do the OCT. Yeah.
Okay, let's come back a little
now,
bit.
other question also,
back.
you see that I tried to wire into the LED. It would not go easily, so we just took the D2. That's one. And the second, we knew we were going to do OCT, so trying to be in a reasonable size vessel.
Okay.
Good. Good.
All right, we're definitely dilating all the way out.
Okay.
Guys, are you doing the contrast injection to the OCT with the manual manifold?
We do have manual fold, but we have assist also.
Sorry, we didn't hear.
No, we have a manual, but in this case, the answer is no.
Okay, ready?
Contrast. If you dilute the contrast in the syringe 50%, you get
Perfect.
Perfecto.
That could be.
But left vein is not covered.
Left vein is covered.
Ostium, not.
No, it's covered, you'll see. All right, let's do the.
Not be covered.
Yeah.
Well, that's why we have OCT right now.
Okay, now we can do OCT.
OCT right now. Okay, excellent. So
pretty good, guys, so far.
Yes.
Watch your wire.
No, I took it out. I'm trying to see if I can get into the LAD. It's not going.
Don't worry about it. Just let it be there.
Go down
Totally
the
fine.
LAD.
The
It's a
LAD
small
is,
vessel.
it's kind of a little bit of a dual LAD system with a septal and a major diagonal, so it's fine where the wire is.
Okay, you're ready for the OCT, yes.
We're ready for the OCT, the same system again.
Well done.
Got it?
Yes. And if you see, entire case, we are not left main, the guide. Yes. And the left main, we keep the guide out most of the time.
Let's see, OCT a little bit closer.
So
OCT, very good. Katja, we're ready for the OCT. Approach the guide a little bit. But the OCT is way distal. We don't need to be so distal.
No, you need to see the distal edge. Okay.
Still not
One
clearance.
second.
Yeah, good clearance.
A little bit back.
Yes.
Okay, 1 second.
A little bit back.
Enabling.
No, it's good.
The OCT a little bit back.
Okay.
Okay. I don't do that.
Let's go.
Can you pull back your...
sorry.
Stop.
So,
Catchy.
1 second.
We're not ready.
1 second, please.
Let's try to do it again.
I will skip this.
Precious.
Okay.
No, not so much. You're in the diagonal now.
Okay.
Okay, let's go. Catchy, are you ready?
Yeah. 1 second. Yeah, 1 second. Enabling. 1 second.
No. We need that.
Calibrating.
No, we cannot. We need the dye.
Yeah, please, Cine, inject.
Cine.
No, because you won't get the contrast into the distal. The reason to do this OCT
beautiful image
point is to make sure the distal part is okay. Frankly, from a workflow standpoint, oftentimes what's easier to do is to do your pot and your post dilatation and then do your imaging. But I think in this case the key is
let's take a 40 high pressure balloon.
Yeah.
What do you think for the left main?
No, left main we have to short stent because it's not covered. Wait,
yeah, 1 second, I will check.
It's fine.
The left main.
Kiski just show us a distal edge and proximal edge.
Sure. Now coming to the distal. Yeah, perfect. You see the perfect landing. No malposition, no dissection to the distal edge. Now coming to the proximal edge. Yeah, stent is all well expanded. Now come to the left main. Now come to the ostial left main. Oh yeah. It's not. But just after the guide, the stent starts. Of course, it's a little bit malposition, but it's just
next to the malposition. The left main,
next to the nodule. It cannot be.
So we got us a 4-0.
So we nailed the ostium.
Yeah.
We nailed the ostium. 4-0-15, please.
So we are going to post dilate the left vein,
Yep.
and I think the rest we are good.
Nailed the ostium. I'm not.
You don't know what nailed the ostium. Okay, let's go to the neocranial and show that.
Guys, so we cannot see the real osteo left main, of course.
But we should.
Let's go. A little higher view. Let's go back.
You went a higher mag.
That's
Can
why
you?
you may honestly, what you may to nail the ostium might need to use a different imaging modality.
Let's see.
No, but actually, even with IVUS, you'll never be able to see the.
Never be able to see that.
Ostium very well. It's only angiography. Okay, let's see here. So let's do a poor man's. Okay, let's get all the windows down.
But the ostium looks mostly covered. There is only like one quadrant without stent straps. But at that segment, the area is pretty good. So,
yes.
And actually, by this OCT imaging, I don't think they need an extra stent.
Very good.
I don't think you need an extra stent either.
I agree with you.
Oh, looks great.
Yeah, I don't think you need an extra stent. The panel here feels like you have covered the ostium for the most part.
But
so
you need
maybe you
the
can just go with
that doesn't exist the most part.
The 15 may be too long. I don't know, George. You have to see because you don't want to hang out beyond the stent.
We're putting a 4015. We're putting a 4015 high pressure balloon to balloon the left main from the and do the pot. Go. 4015 balloon.
Yeah, but you're going to hang past the bifurcation.
What, Roxana?
I want to hang out a little bit outside the.
I would
It's
have
just you're
chosen
either
a
gonna-
shorter balloon.
Why?
No,
It's
you're
no
good.
good.
This is 15.
That's
Look at
15. Look at it. Let me show you
Look at
where
the
it is
length.
a 15. It's
Yes.
exactly.
Right.
Exactly.
There. Go
It's
up.
perfect pot.
Yes.
I think that
Don't get crazy.
Yeah,
Okay.
I think the ostium outside the stent, in my opinion, but the stent ended inside that portion, but
Yes.
I think.
and that's the portion you're not going to be able to see by OCT.
The ostium not
because-
covered.
But you can see that the stent does take a bend there. Very good.
Okay. No, low pressure
one?
because 4-0, but
wait.
left is about 3-5, so just go about 10-12. Good.
All right.
Okay,
We
good.
do a little
Done,
massage
done.
at 8.
Yeah,
Very
so
good.
Normally, you do this in LAO caudal to make
Listen.
sure that you hadn't got your
LAO caudal. LAO caudal we requested. Move the things a little bit down, please. LAO caudal. We come into LAO caudal. All right.
Go
Just
low
to make
mic.
sure the distal placement of that balloon, it's usually a good option.
Well, guys, you've done a great job. We're gonna
Yeah,
need to
very
go to Emory.
Well, it's very clear over here that we nailed the ostium. Thank you very much for your attention.
Looks really
Dr.
good,
Kinney.
guys. Great job.
Thank you.
Thank you,
Well
Dr.
done.
Kinney. Thank you, team at Mount Sinai. You make us proud. Beautiful job, guys. Beautiful. Thank you.
In 30 minutes or less.
To Atlanta.